Our latest add-on to our intensive care at home nursing service is to also contract an intensive care specialist. And today I want to talk about how that's improving the clinical care delivery for one of our clients. And I want to make it very specific today. My name is Patrick Hutzel from intensivecareathome.com. And this is another video blog about the client care that we are delivering. So today's question is very specific because we had that question again from a funding body of one of our clients that we're working with. So how does an intensive care specialist improve the clinical care for a 24/7 critical care nursing home roster for a client with a TBI, traumatic brain injury, spinal cord injury, asthma, suprapubic catheter? Client's GCS is between 8 to 10. He's got a PEG tube. He's airbow dependent. He's on the airbow with intermittent oxygen requirements. He also has intermittent seizures and epilepsy. He's got episodes of low sodium, needs deep suctioning, and he's got left hemiplegia and deranged LFT. So, like I said, we've been privately contracting an intensive care specialist for more than one of our clients now, and we believe that's obviously improving the experience of our clients and their families. So, intensive care specialist, also known as an intensivist or ICU consultant, plays a critical role in improving the clinical care of a complex client at home, like the one we're looking at today. Here is how an intensive care specialist can enhance the care for a 24/7 critical care nursing home client with TBI, spinal cord injury, epilepsy, respiratory issues, PEG, SPC, and more. Number one, clinical oversight and protocol development. By developing custom care plans, develop individualized protocols addressing GCS monitoring, seizure precautions, PEG care, SPC maintenance, respiratory support, and sodium balance. Also, they can develop emergency algorithms, implement clear action plans for seizures, desaturation, sodium drops, and respiratory distress. Airway management protocols, guidelines for deep suctioning, airbow use, and O2 weaning strategies. Number two, multidisciplinary team coordination. By doing routine case reviews, weekly or bi-weekly reviews with nurses, neuro rehab specialists, respiratory therapists, neurologists, and dietitians. And of course, escalation pathways, set up criteria for when to escalate at-home care or last resort to shift to hospital care versus manage on-site visits. I mean, that's one of the goals for us, to avoid hospital care altogether, right? Number three, training and capacity building, nursing education, provide ongoing training on seizure response, PEG tube troubleshooting, deep suctioning techniques, signs of aspiration, infection, or deteriorating neurostatus. Simulation drills, practice emergency responses for airway blockage, seizures, or hypotensive episodes. Number four, monitoring and technology integration. Vital signs tracking, set up digital or manual systems to monitor sodium levels for hyponatremia trends, liver function tests for LFT derangements, respiratory rates and O2 sats seizure logs, neuroassessments, regular GCS scoring, pupil response, limb tone changes. Number five, medication and nutrition optimization, anti-epileptic management, ensure therapeutic drug levels, minimize sedating interactions, sodium management plan, address hyponatremia with fluid restrictions, sodium supplements or medication if needed, liver-friendly medications, adjust drug choices considering deranged LFTs, PEG nutrition, collaborate with the dietitian for high-calorie, low-salt, liver-safe formulas. Number six, respiratory care optimization, airbow settings, monitor and adjust humidification and flow to match patients' respiratory needs, oxygen goals, maintain optimal oxygenation without overexposure because of the risk for CO2 retention in some cases. Pulmonary hygiene, chest physiotherapy, postural drainage, and suctioning protocols. Number seven, prognostication and family communication, regular family meetings to update clinical trajectory, clarify goals of care, rehabilitation versus maintenance versus palliative, and set expectations. And we have used these intensive care specialists for other clients as well to oversee home TPN programs. And we're using the intensivists for other clients as well to oversee our programs. It's really the next level of our care that we are providing. So, and if you want to know more about it, at how we use our intensive care specialists, just contact us here at intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. So with all of that said, with Intensive Care at Home, we are currently sending our critical care nurses into the home 24 hours a day, all around Australia, in all major capital cities, as well as in all regional and rural areas. Therefore, we are providing a genuine alternative to a long-term stay in intensive care for ventilation, tracheostomy, home BiPAP, home CPAP, ventilation without tracheostomy, and tracheostomy care without ventilation, home TPN, home IV potassium infusions, home IV magnesium infusions, IV fluids, and IV antibiotics. We're also providing cough assist management at home, ventilation weaning at home. We're also providing central line, peak line management, Hickman's line, as well as port management at home. We're also providing nasogastric tube, PEC tube management at home, IDC, indwelling catheter management at home, SPC, suprapubic catheter management at home, as well as palliative care management at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to an emergency department. That means we're also in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs between $5,000 to $6,000 per bed day. Intensive care at home costs between $2,500 to $3,000 per bed day. And we're freeing up the most sought after bed in the hospital, which is the ICU bed. Most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. With intensive care at home, we are currently operating all around Australia and all major capital cities, as well as in all regional and rural areas. We're an NDIS-approved service provider all around Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as the Department of Veteran Affairs all around Australia. Our clients and we as a service provider have also received funding through public hospitals, private health funds, as well as departments of health. We are the only service provider in Australia that has achieved third-party accreditation for intensive care at home nursing in 2025. We have been achieving this high level of accreditation since 2012. No other provider in Australia has achieved this high level of accreditation in the community and has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, and that enables us to look after the highest acuity adults and children in the community in Australia safely. If you're at home already and you're watching this, or you're stuck in an ICU and you realize that you don't have the right level of support or that you're not in the right environment, I'll give you a very tangible and real-world example today how we can help you. One of our first clients, when we first got started over 13 years ago now, in 2012, was a client who was at home initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, disability support workers cannot look after a critically ill patient on a ventilator with a tracheostomy at home. That is dangerous, and it's negligence having support workers looking after a client at home on a ventilator with a tracheostomy. That is like flying the airplane with the cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies or is at very high risk of dying if they don't have a stable team of critical care nurses looking after them 24/7 at home. This is actually evidence-based in the community and is documented in our mechanical home ventilation guidelines that are evidence-based that you can find on our website at intensivecareathome.com. Think about it. In an intensive care unit in a hospital, you wouldn't have support workers looking after a critical care patient on a ventilator with a tracheostomy. So why would anyone in their right mind would do that in a home care environment where there are fewer resources? So eventually this client in the ICU that he was basically living in found out about us, and we were proving our concept with this ventilated and tracheostomy client very fast. When we worked with the ventilated and tracheostomy client, we sent him intensive care nurses 24 hours a day, and he never ever went back into ICU ever again. We were proving our concept there very fast. The insurance body saved half of the cost of paying for the intensive care bed. So it was a win-win situation all around and for all stakeholders. We can do the same for you if you're not safe at home, which includes the advocacy for funding that goes along with it, which ties in with what I just talked about just now. Or we can do the same if you're stuck in an ICU. We have always successfully advocated for our clients, otherwise we would not be in business. Please reach out to us, we'll make it happen for you as well. We will take you through the right steps. This is also why we are providing level 2 and level 3 NDI support coordination. We have a team of NDI support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Riches, one of our NDI support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog below the video. We're also providing TAC case management and WorkSafe case management in Victoria with Lucy McCotter. If you're an NDI support coordinator or a case manager from another organization watching this, and you're looking for nursing care for your participants, please reach out to us as well. If you're looking for funding for nursing care for your participants and you don't know how to go about it and how to advocate for it, what evidence to provide, I encourage you to reach out to us as well. We will help you with the right level of funding and with the right level of advocacy. We're also providing NDI specialist nursing assessments done by critical care nurses with a legal nurse consulting background. If you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic and high-performing team of critical care nurses, we are employing hundreds of years of critical care nursing experience combined. If you're looking for a career change, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be absolutely delighted hearing from you. I have a disclaimer though, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients also do want the same staff coming over and over again because they are so vulnerable and so special, and that's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We're looking for consistency and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts and you're really keen on building relationships with us and with our clients. And if you are an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds. And in most cases, you won't even pay for it. Even if you do pay for it, it is so much more cost effective than what you're paying in ICU and ED settings for, and you get the same level of care and simply more patient and family satisfaction because you also want to partner with your consumers. If you're in the US or in the UK and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecareathome.com. If you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next and what you think about this video. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.